Thank you for that presentation. I'm always excited when I hear something new from you. And you brought up a really important point that I did not touch on, but I hear it, and that is that you alluded to the fact that men also have sexual problems. And I will tell you that in my practice, perhaps 40% of women in the menopause are not having sex, not because it's a problem with them, but in fact it's a partner issue where the partner is either having erectile difficulties, difficulty maintaining or achieving an erection, or perhaps a secondary premature ejaculation. So I assume that you see that as well.
I see a great deal of that. And what often happens is one person will have the dysfunction, it won't be treated, and the other person will develop a response and often a sexual dysfunction to that as well. For instance, the man that you allude to with ED, the woman will often wonder, does he love me anymore? Is he having an affair? Is it the 10 pounds of weight I've gained? And as she then gets into it, he then begins avoiding lovemaking with her because he's embarrassed and ashamed. And she then begins to feel badly about herself and their relationship and may develop a desire disorder as well. So we can see this. I can give you examples going back and forth for the woman who has pain. Often we've seen, and the research will bear this out, that men learn to ejaculate quickly. They condition themselves because they don't want to hurt the woman. And then she complains that the man has premature ejaculation, and then he has to get that treated. So we see this back and forth with one or the other, especially, in the fourth and more so the fifth decade of life, where men and women, due to their aging issues and health issues and medication issues, develop sexual dysfunctions.
I remind my peers when they discuss their awkwardness about bringing up sexual concerns with their patients is that they themselves aren't so confident with their own sexual self. And so I try and give them just certain questions like, are you sexually active? And that's either a yes or a no. If the patient says no, then I ask no interest or no good partner. And so that sort of takes me into, is it you, is it him? And sometimes, of course, I get both. But one of the things that I encourage my peers is to seek and partner with a certified sex therapist or sexual health provider in their area so that when they come across a problem that seems too intense for them, at least they've addressed it with their patient and are now referring to the person in their neighborhood. Now, I tell them to search the web for certified sex therapists in their area, but how would you suggest that I help these docs find the experts in their region?
Well, there are a number of professional societies, as you know. So if it's women, we can certainly look at the clinicians that are in the International Society for Women's Sexual Health, or ISWISH. And if you're looking for a sex therapist, there's the Society for Sex Therapy and Research, and there's also ASECT. So I think between ISWISH, STAR, which is the Society for Sex Therapy and Research, and ASECT, which is AASECT, that you can find somebody in your area. And I would suggest it's like what you and I did. We got to know each other. We shared a meal, a drink. We got together at a conference. And to find people in the area, because you need somebody to go back and forth with, back and forth. And really you're working as a team, even if you're not in the same office.
You're right. That team is a host of individuals. Some docs, I say, look, especially the male physicians, it's very interesting. I'll say, look, if you're not interested in opening the dialogue with these patients, often the nurse practitioner in your practice is seeing those well visits anyway, which is often when this conversation comes up. So I say, educate your nurse practitioner. Check their enthusiasm and willingness to attend ISWISH meetings or SMSNA or ASECT or whatever to find their interest in treating the patients. So our nurse practitioner colleagues tend to play a key role in many practices, as well as the pelvic floor physical therapists, and so forth. So it really is an integrated group of individuals helping the same patient.
Yes, absolutely. I think that's really what the future of sexual health treatment is bringing together these, I call them teams, of different specialties: physical therapy, endocrinology, family practice, gynecology, urology, and a mental health clinician. These are the ways that we can really best manage the patients and couples with sexual issues.
So we talked a lot today about many of the medical and emotional and sociocultural and interrelational problems affecting sexual desire. But in fact, both you and I probably see, I know I do, and I want to know about you, patients who don't really have any of those things, and they are stable, they're not on any mood meds, they don't have any medical problems, yet they present with low desire. They're often premenopausal women, and they still want sex. They have a great partner. So I'm seeing these patients, and I'm actually thrilled that we finally have something to offer them with flibanserin.
Yes, and those are the ones, if you remember the slide that I put up, which is sort of like that Russian egg where there's groupings. What happens is there's this FSIAD or HSDD where it really seems mysterious. And there are two issues there. Either the woman has a secret that she hasn't shared with you or me, or this is some kind of a biological problem that we just don't really have a sense of what it is. And perhaps, especially when we think it's not the secret, but more the biological problem, where flibanserin and some of the other drugs that may come down the line may be most appropriate for this sort of woman. Dr. Whelihan, let me ask you some questions as well, because I often see the sequelae of medical problems, and maybe you can talk for a minute about, I think, one of the most important issues, the woman who has breast cancer, and the woman who has breast cancer who wants to continue a sexual life and is placed on medication or feels the change in her body image. And what is it that you and I and the rest of the team can offer women like that?
Yes, this is not an uncommon patient at all, and I'm sure that you see them, and I do as well, for some of the issues just regarding their appearance. They're missing a breast, or they don't have the sensitivity in their breast anymore, or they have a disturbed image of themselves as a sexual person, as a woman, as a beautiful woman. And so the emotional aspects of that are huge. But there are some medical things involved with breast cancer that also play major roles.
Absolutely.
Since breast cancer is often an estrogen or progesterone-dependent tumor, the therapy has always been directed at taking down the estradiol level and the hormone level as severely as possible to protect the patient from reoccurrence. And so they do this often with an aromatase inhibitor, which was present on one of those slides that I presented with a whole bunch of meds on there. And so aromatase inhibitors severely limit the estradiol. It just sucks the life out of women in regard to estradiol, and it contributes to a significant low energy, insomnia, loss of desire, and vaginal dryness. So sometimes when I'm picking apart this problem that I have very few things to offer, I then have to begin speaking about the things we can manage, perhaps not on label, but certainly with lots of data out there saying that this is being used. And so my first line in discussing painful sex is to try and use an ultra-low dose of estradiol cream to the introitus and vulva and in the beginning of the vagina where all the pain is occurring. And by using as little as 1 gram twice a day to the introitus and the vulva, and I actually show them, I measure it up and I actually apply it with my fingers the first time while they're in the office to show them where it's okay, because they all don't want to put it in them because of their fear of breast cancer. And then I try and share some of the existing data that's available on the use of vaginal estrogen products and the actual estradiol levels that occur with these. So we have to, when I talk to my oncology colleagues, I say, while you're busy saving her life, I am in charge of her quality of life. So I do not get a lot of pushback from my oncology peers because they understand that I'm doing as much safety as I can. I actually offer to draw an estradiol level about 12 weeks post-therapy to show that there's no change based on the product that I'm giving them. And then there's other products out there if that is insufficient that I can use in my patients. But again, most studies are not done in breast cancer patients, so we are using these off-label.
So another issue that we tend to see is the young woman who has a hysterectomy and an oophorectomy and suddenly is hit like with a hammer and loses her sexual interest, is not hormonally replete anymore. What is it that we can do to help these women?
Oh, yes. That really is significant, especially in that young woman, say in her 30s, who had a complete hysterectomy with oophorectomy for, say, endometriosis. It hits them like a ton of bricks. It is nothing like what naturally menopausal women experience, and there's actually research looking at this. They are far more impacted by this. So again, we have to look at desire and energy and sleep and pain with intercourse. These patients are often good candidates for systemic estradiol or estrogen use, assuming they don't have an estrogen-dependent cancer like an endometrial cancer. But usually these young gals have endometriosis or other non-related conditions. Some papers argue that if you're going to give estrogen replacement or therapy to a patient who has had endometriosis recently, that you should give a little progesterone, but we generally do not use progesterone in a lady with a hysterectomy unless it's under certain circumstances. So, but those young girls probably all would benefit from off-label use of testosterone because we know that testosterone is critical in the younger woman, and that while we lose it over the years and as we age, that it seems much more impactful to that gal in her 20s or 30s that ends up losing her ovaries for one reason or another. Now, there are other medical reasons for losing ovaries at a young age, but I urge my colleagues that when they're doing a hysterectomy on a patient, you know, in the old days we were taught if they're 40 or over, take out the ovaries to reduce their risk of ovarian cancer. Well, now the impact on cardiovascular health and sexual health may be more impactful than that thought of risk reduction that we were doing. And so a lot of docs are having a conversation with their patients and opting to leave in the ovaries. Many are taking the fallopian tubes because there's some thoughts that ovarian cancer may actually begin as fallopian tube cancer. So there's a lot of discussion and educating our peers as to the importance of the ovaries making both estrogen and testosterone is important.
Yes, and these women and certainly their couples, they're hit so hard with this because even though we may speak to them, the effects are profound and still unexpected because they just had no idea that this would happen. So this is an important group that we have to work with who lose their desire, who experience painful sex, and sometimes it then impacts, as you always use the phrase, the snowball effect on the couple.
Without a doubt, the psychosocial aspect is key. After all, it probably explains why the placebo effect is so great in these sexual health clinical trials, because the placebo group gets counseled about good sex and lubrications available. And so you and I both know that just the very moment we start talking to our patient about sex, they already feel better, or they already start holding hands, or somebody gets a pat on the butt. I observe all of these behaviors when I see patients, and it's the very fact that you're having a conversation, which is the psychosocial discussion and the therapy that you do that follows that up, that is critical.